I have the pleasure of introducing our next speaker, Dr. Nancy DeMoore, who is a surgical oncologist. She did her general surgery residency at Boston University, followed by a surgical research fellowship at Harvard and a surgical oncology fellowship at Memorial Sloan Kettering. She was previously professor of surgery at UNC Chapel Hill, and is currently professor of surgical oncology and the medical director of the Medical University of South Carolina Breast Center, and has a BMW endowed chair in cancer research. And she's going to talk to us about breast cancer prevention and screening.
Thank you. Well, good afternoon. So what I'm going to talk about today is I'm going to start with breast cancer screening, and this is a very controversial area. And I really want to go through the data and really discuss why there's controversy in the different recommendations for breast cancer screening. My goal is I hope that I can convince you that screening, as in breast cancer treatment, really needs to be personalized to the individual patient. I'm also going to talk then about how we screen people who are at high risk and how we actually identify people who are at high risk for breast cancer and what we can do to prevent breast cancer. And I do not have any disclosures. So about 12% of women will develop invasive breast cancer if they live to age 90. It is the most commonly diagnosed cancer in women. And in 2016, the statistics are 246 new invasive cancers diagnosed, 61 non-invasive cancers, and about 40,000 women die annually. So this is a very important disease. There are benefits to screening mammography, and there are potential harms to screening mammography. And I'm going to go through the data for each, but just as an overall, the benefits of screening mammography is that it can save your life. And I'm going to go through the data for this, but finding breast cancer early can reduce the risk of dying from disease by 15 to 36%. And that's really a lot. That's really what we would expect for giving chemotherapy for 4 months. So that really is a very significant benefit from screening. Additionally, if you find a tumor earlier, sometimes you'll have less invasive surgery. A patient with a smaller tumor might be more likely to have breast conservation rather than a mastectomy. They may just only need a sentinel node biopsy and not need to have a full lymph node dissection. So finding a tumor that's smaller sometimes can avoid less radical surgery. And sometimes, if you find it at an earlier stage, you can avoid chemotherapy. So there certainly are benefits to screening mammography. So why is there controversy? There's controversy because with every screening test, there is a potential harm. Now, the first I'm going to discuss, there's no proof of this, but there is a concern that could it be that we're overdiagnosing cancers that might not be life-threatening. And our patients undergoing treatment for cancers that will eventually progress. And this is a valid concern, but there is no data for this because we simply don't have large cohorts of untreated early-stage breast cancer. But the other concern is for false positives and what this can do in terms of additional testing and anxiety. And so I just want to review what a false positive is. So that's when a patient gets recalled for an additional views, and there's no abnormality, no cancer is found. Now, sometimes when you read the literature, you'll hear of very high false positive rates. And when you see these very high false positive rates, you have to differentiate between a false positive being that the patient got recalled for additional views. And if you think about it, that really isn't a big deal. Studies have shown that these have not really had potential harm on patients. Sure, when you get that phone call, you need additional view, you may have some anxiety. But this really, if you think about for yourself, is it really that big a deal to come back and have an additional view? When you see the really high false positive rates, that means that you need an additional view or an ultrasound to clear something up. I think the thing that all of us can really agree upon, what can be more harmful to a patient is a false positive biopsy. And what that is when there's an abnormality that's detected, it's given a BI-RADS4, meaning that it's suspicious, and a biopsy is needed, and the patient actually undergoes an invasive procedure and has a biopsy. And that is an invasive procedure, and if that comes back normal, that's a false positive biopsy. And I think that's where some people really have the concern is, are we doing so much screening that we're causing all of these biopsies that might cause some bruising or hematoma or more anxiety. So I want to go through a study that looked at the benefit of survival from screening mammography. So the first question I'm going to ask is, the mortality from breast cancer is not reduced by screening mammography in women in ages 40 to 49. True or false? Okay, so we'll go through the data. So this is a really good paper if you want to do a deeper dive into this. It was published in JAMA. It's really what the American Cancer Society based their recommendations on. And they did a meta-analysis of phase 3 studies as well as case cohorts and looked at the benefits and harm of screening mammography. And they looked at the benefit of reduction in breast cancer mortality, and they stratified it by age. So in the 40 to 49-year-old age group, and this is really the group that there's all the controversy of whether or not to screen, the meta-analysis showed a 15% reduction in breast cancer mortality, and that's comparing to the unscreened population of the same age. So again, what do we do as clinicians to improve mortality by 15%? We give chemotherapy for that. Okay, so this is a very significant increase in survival from screening in this age group. When they looked at the women who were over 50, there was a 14 to 23% reduction. The biggest magnitude of benefit was in the group between 60 and 69 years of age. And interestingly, there was no reduction in survival between the women who were over 70 in terms of screening mammography. And this is something that I think we need to keep in mind as we screen our elderly population. And this really doesn't tease out why is this. You could hypothesize that there's going to be more patients in this group that are going to be dying of other causes, and that may be why you're not seeing the survival benefit. And I think this might really go into picking your patients. If somebody is on dialysis with congestive heart failure and dementia, they're probably not going to get a survival benefit by a screening mammogram. But if you have a woman who's 72 and completely healthy and active, not that there's data to say this, but that patient may have a survival benefit. I think you need to use a little bit of common sense that we're probably not seeing the survival benefit because this is a whole group of patients with a diverse set of comorbid factors. In this meta-analysis, they tried to look to see if there was qualitative evidence for the association between screening and overdiagnosis. And they didn't find that there's actual hard qualitative evidence to say at this point in 2016 that we're overdiagnosing cancer. Now that's different than saying that it's not. It's just that we don't have data. And again, we don't have data that we're overdiagnosing cancer because we simply don't have large populations of people that aren't getting treated for their breast cancer. So what about false positives? So they looked at what is your chance of getting a false positive biopsy. I'm really excluding the whole data on the false positive callback because really, that's really not a big issue to come back and get an additional view. But this really isn't an issue of a woman undergoing an additional biopsy from a false positive screening mammogram. And so they broke it down into when they started their annual mammogram and what the risk was on the single exam, their 10-year cumulative risk, and their lifetime risk if they continued to screen to age 74, and whether their screening was done annually or biannually. So for women who started at age 40, the chance of having a false positive biopsy on the first exam is about 2%, not much difference if they started at age 50. The 10-year cumulative false positive rate was about 7% versus 9%, so really not very different. And if they screened to age 74, the lifetime risk of having a false positive biopsy was 25%, slightly reduced to 20% if they had it annually starting age 50. Now the USPTF, which I'm going to show you later, is recommending biannual screening And the reason that they're recommending this is that you really do decrease a false positive biopsy rate if you screen biannually. So if you start at 40 and you screen biannually, you reduce your lifetime risk of a false positive biopsy to 17%. And if you start at age 50, you only have a 14%. So this is information that I think we need to really be able to discuss with our patients. Because the question is, for your individual patient, what is her value system? Is she someone who really wants the maximum benefit of survival if she were to get breast cancer? And a false positive biopsy doesn't matter to her. Well, that's someone who really should be starting at age 40 and do annually if she's okay with accepting about a 25% chance that she's going to need a biopsy at some point. We all have patients that are very afraid of biopsies, and they're very concerned about undergoing a lot of invasive procedures. And they may say, I'm never going to get breast cancer. And for that patient, maybe that's someone who really should go to a less intensive screening. But they really need to look at the numbers. Is a reduction from 25% down to 14%, how much is that worth it to that patient? I mean, if it were me, that's not a big deal for me, okay? I would much rather have a 15% improvement in survival than to reduce my risk of having a biopsy by 10%. But that's my value judgment. I think we need to discuss this with our patient and see what their value judgments are. This is really interesting and somewhat hard to know what to do with. What is the benefit of a clinical breast exam? So this is a question. There is clear evidence that clinical breast exam in asymptomatic women improves survival. Yes or no? Okay. So in the same study, they looked at a U.S.-based case control study. And what they found was no association between receipt of a clinical breast exam within 3 years and breast cancer death compared to no screening. And this is in women between the age of 40 to 65. So in other words, they looked at women who did have a breast exam within 3 years and those that did not have a clinical breast exam within 3 years, and there was no difference in mortality. 21% of women who had a clinical breast exam within 1 year of breast cancer diagnosis had a finding that was suspicious or intermediate, which means about 80% of women who had a clinical breast exam and then were diagnosed with breast cancer had a normal exam. Okay? The addition of a clinical breast exam to mammography detected 0.4 in 1,000 more cancers with an extra 21% false positive finding. So that's really not giving a big bang for your buck. And so their conclusion was that there was no association of clinical breast exam alone or in association with mammography with reduction in breast cancer mortality. So now I'm going to review the American Cancer Society screening recommendations, and this is the recommendations that came out last fall. And so they state that they recognize that the incidence of breast cancer starts to increase at around age 40. And they recommend that all women should have annual screening between the age of 45 to 54. But what's really important about their recommendation is that they recommend that women between the age of 40 and 44 should have the opportunity to begin annual screening. I.e., if they want it, their doctor should order it, and hopefully their insurance would pay for it. Again, this is really bringing the patient's values into the discussion. And at age 55, one could transition to biannual screening or have the opportunity to continue annual screening. In terms of when do you stop, this is really an important issue. They recommend continue screening as long as health is good and life expectancy is greater than 10 years. This is really very rational, and I think we all have to start thinking about when to stop screening. One of the problems we as breast surgeons face is when a patient who really has a very poor quality of life, dementia, again on kidney dialysis, gets a screening mammogram, and then they get diagnosed with breast cancer, and we have to have these long conversations. And you really ask yourself, should that patient even have had a screening mammogram? To cover yourself legally, it's the American Cancer Society. They actually do give a stop point. Okay, you really should stop if the life expectancy is less than 10 years, and you're perfectly fine in doing that. What's really controversial is that the American Cancer Society does not recommend clinical breast exam because the data shows an increase in the false positive rate and no data on improved outcome. And I really want to talk about this. I mean, this is something that I think is very hard for all of us to say we're really not going to do physical exams on our patients. I think that we just have to, I couldn't advocate. I couldn't say here and say don't do a physical exam. And I think most of you would probably feel the same way. And I certainly have seen many patients whose cancers were diagnosed by a really good primary care physician doing an exam. And sometimes even the imaging's negative and we go ahead and we do a biopsy. But I think what this means is that, for one thing, we need to really think about where do our healthcare dollars get spent. So spending our healthcare dollars on screening mammography is really important. But if we're spending our healthcare dollars on screening asymptomatic women with physical exam, that's probably not a big bang for your buck. So if you were going to think about where am I going to invest a lot of money, it probably shouldn't be for just physical exams. It should be for screening mammography. But if you have a patient that comes into your office and you're listening to the heart and lungs and they lie down, you're going to do an abdominal exam, how does it really, it doesn't really spend too much more healthcare dollars to go ahead and do a breast exam. I think we have to really think why are we not detecting more cancer with our clinical breast exam? Number one, maybe it's because if you're in a practice where all of your patients are getting mammograms, then their small cancers are being picked up and it's unlikely you're going to feel something. But it may be that we're not training our medical students well enough. Maybe we need to be spending more time on how to do a physical exam. So I don't think that this is the end of the story. I don't want you to take away from this message, I'm going to stop doing physical exam on patients. But I think we just have to understand the data. We shouldn't fool ourselves if their exam's normal, that they don't have cancer. And I really think that as a society, we shouldn't be spending large amounts of money on screening with clinical breast exam. That really should be reserved for mammography. Now I'm going to go into the United States Preventive Task Force screening recommendations, which are very different than the American Cancer Society recommendations. And so they came out last fall with recommendations for biannual screening starting at age 50 to 74. And for all women with regular mammogram screening, they say for all women, regular mammogram screening increases the risk of diagnosis and treatment of breast cancer. And that's an amazing statement. Regular mammogram screening increases the risk of diagnosis and treatment of breast cancer. Okay. That would otherwise have remained non-threatening. There is no data that we are detecting cancer that if we didn't treat would be non-threatening. I'm not saying that there's some cancers that will never progress, but in 2016 we don't have the ability to diagnose a cancer and predict which one is never going to progress and which one is going to cause death to that patient. This is an active area of research that we should be pursuing. Is there a molecular basis? Are there imaging techniques that can help us define which cancer is going to grow and which cancer isn't? We presently do not have that ability. And so they're saying that screening increases the risk of diagnosis and treatment. And that's something that I personally disagree against. They do discuss 3D mammography, which I'm going to go into detail. They say current evidence is insufficient to assess the balance of benefits and harms of 3D mammography, and I will discuss that in more detail. For women with dense breasts, and I am going to discuss dense breasts, current evidence is insufficient to assess benefits and harm of adjuvant screening using ultrasound or MRI. Now, this is really the problem. They gave a Category C recommendation for screening between age 40 to 49 and a Category B for biannual screening for age 50 to 75. Now, in the ACA, it's written into the law that insurance companies have to pay for screening that get a Category B for USPTF, but they don't have to pay for screening that USPTF gives a Category C. So theoretically, insurance companies could deny, based on this recommendation, screening for women between age 40 and 49. Now, presently, that hasn't happened, and I think that's because, as I'll show you, all of the breast cancer societies have really come out against the USPTF recommendations, and there's a lot of patient advocates. But this is why we take what USPTF says so seriously, because it's actually written into the law that they determine who gets screening studies and who doesn't. So I wanted to just to summarize the screening recommendations. So American Cancer Society, USPTF says 50 to 74 and biannual. I really like the American Cancer Society's recommendations because it really gives options to the patient. Again, I'm a person, if I'm age 40, I want to be as aggressive as possible. I want to have that survival benefit, and I don't care about false positives. And you have many patients that are like that. So I believe they should be allowed to have that benefit of increased survival. And some patients don't want that. They want to reduce their risk of biopsy. They should be allowed to go to a less intensive screening program. American Cancer Society does recommend stopping screening when appropriate, and they do recommend for shared decision making between age 40 to 45. Now, American College of Radiology, I'm going to show you one of their statements. They came out and disagreed with all of this, and their stance is that they want the most benefit in terms of survival, and so they believe in start screening at age 40 and annual. The NAPBC, this is the American College of Surgeons accreditation for breast programs. They came out and recommended continuation of 40 and annual. This was a response from the Society of Breast Imaging. USPTF recommendations, if followed, will result in thousands of unnecessary deaths each year and thousands enduring extensive and expensive treatments than if their cancer had been found early in mammography. As goal to save as most lives as possible, the American College of Radiology and Society of Breast Imaging continue to recommend annual screening at age 40. At MUSC, we recommend screening at beginning age 40, but we do also recommend shared decision making with the patients and really a discussion about that. I do want to talk about breast density. This is actually very important because for patients, and also because South Carolina has recently passed a breast density bill, which I'll talk about. So what does all this mean? So fatty tissue is black on mammogram, and this is a almost entirely fat breast. Tumors and calcifications are white, so it's very easy to see calcifications and tumors on a black background. Dense breasts are white, and so it's more difficult to see white calcifications and white tumors on a white background. And so this is why you actually get a decrease in the ability to detect breast cancer if you have a dense breast. And so many states have enacted what's called the breast density bill. And what that means, and this is really driven by patient advocates, what that means is that if a patient has a dense breast, the radiologist has to tell them that they have a dense breast and that that a negative mammogram is less sensitive at detecting breast cancer. And so your patients will be getting this, and I'm going to go through what do we do about that, because that can cause a lot of questions. So here's a question. An average risk patient with a dense breast should have a screening breast ultrasound. Okay. So if we look at the sensitivity of mammography, ultrasound, and clinical breast exam by breast density, you can see that mammography is excellent if you have a very fatty replaced breast. Again, not good for an extremely dense breast. But ultrasound actually isn't very good either. The sensitivity for a dense breast is only about 76%. And for clinical breast exam, it doesn't matter. It's not good at all. There have been studies that have compared screening mammography alone versus screening mammography with ultrasound. And there is a large increase in the false biopsy rate when you add screening ultrasound, and really not an increase in detection of cancer. So if you have a not high-risk patient who's completely asymptomatic, the present recommendations are not to do a screening ultrasound, and it's unlikely that that would be reimbursed by the insurance company. So what do we have? Well, we do have 3D mammogram, and so this is digital breast tomosynthesis. And this is actually better for dense breasts, and one of the major limitations also of routine mammography is overlapping tissue, and tomogram reduces the visualization of overlapping structures. And so presently patients get a 2D mammogram and a 3D. And right now there are phase 3 randomized studies which are ongoing. We don't have the results of the phase 3 studies. We do have results of a cohort study called the STORM study. So this is screening with mammogram or tomosynthesis. And so this is more of a retrospective study, not a prospective randomized study. But in the phase 2 studies, there was a 17% reduction in the false positive rate with a 3D mammogram. Now, this is really important because the reason that USPTF does not want to start screening early is because of the false positive biopsy rate. And it looks like with the early data that 3D mammo is reducing the false positives. So that's really good. And there actually is an increase in detection of cancer with the 3D mammo. This is not something that is going to be in any society guidelines because we don't have phase 3 data yet. But if you're sitting there, what do I do with my patient with dense breast? There's no indication for screening ultrasound. You're not going to get a breast MRI reimbursed unless they're high risk, and you're going to have a lot of false positive with breast MRI. But I would get a 3D mammogram for a patient who has dense breast at present. I think that would be a very good thing to do. And this is just a kind of a picture of what you can see. So this is comparing the cancer seen here with 2D versus a 3D here. And one thing that I will say is presently the radiologists are doing the 2D in addition to the 3D. So the 3D actually does presently have more radiation. The FDA says that the radiation exposure is safe. We all know that we have patients that are very concerned that mammography causes cancer. It's clearly data that it doesn't, but still patients have that concern. There is more radiation with a 3D. Probably in the future there'll be other techniques where they won't have to do the 2D, but right now there is more radiation. Also, in terms of reimbursement, patients have to check with their insurance companies. Not all insurance companies will reimburse for a 3D. Some are, some aren't. They will pay for the 2D, and so sometimes patients will have an $80 copay. So that's really what we have for screening the asymptomatic patients. And now I want to talk about how do we define if someone is at high risk for breast cancer. And this is really important because we really want to talk about preventing breast cancer rather than treating it. So we're going to talk extensively about family history, but that's certainly a very important thing. Is there a genetic component? Risk factors, there are endocrine-related risk factors such as early menarche, late menopause, nulliparity, or late onset of first child. If someone's had previous radiation, and this is something we typically see for survivors of Hodgkin's disease when they have mantle radiation, if they have mantle radiation before the age of 30, there's an extremely high rate of developing breast cancer, so those patients would be at high risk. Previous breast cancer increases the risk of a second cancer. Ductal carcinoma in situ also increases the risk. Lobular carcinoma in situ is not a breast cancer. That name stuck. It was labeled that in the 1920s, and no one ever changed it. It's actually not cancer. but it does put someone at high risk for developing breast cancer. And atypical, if someone has a biopsy that has atypical hyperplasia, that greatly increases the risk of developing breast cancer. So you can take these factors and you can get an assessment of someone's risk by using the Gail risk assessment. Now, this is a model that you use in someone who you do not suspect a hereditary breast cancer syndrome. So you don't use it if you think there's a BRCA1 or 2 mutation, because this doesn't take into account paternal transmission of breast cancer. But what this, all those factors that we discussed, patient age, family history, really just first-degree relatives, and their endocrine exposure, will calculate both a 5-year risk of developing breast cancer and lifetime risk. And all you have to do is just put in Gail risk model, and the one you want to click is the cancer.gov website, and it will come in. You put that information in, and you're going to get a 5-year and a lifetime risk. And so what do we consider high risk? Well, I think it's really good to look at the lifetime risk, and anyone who's greater than 20% is considered to be at high risk. That's what the American Cancer Society has adopted. And in terms of paying for additional imaging, that's what the insurance companies have adopted. In terms of enhanced imaging, it's that trigger of a greater than 20% lifetime risk. And just remember my first slide, our lifetime risk is about 12% lifetime risk as the average person. So this is 20% would be considered high risk. And we also look at the 5-year risk. This is the number, the 1.7% 5-year risk. That's the number that has been used in the prevention trials for patients to accrue to that. It's actually not really that high of a risk, and most patients on the prevention trials had the average lifetime risk was 5-year risk was more about 3 to 4%. But the 1.7% is a number that you can technically use if you want to use endocrine therapy for chemoprevention, although I think that would be a little bit aggressive. I think the lifetime risk really gives a better estimate of that. So I'm going to talk about people who are at high risk not from a genetic syndrome. So you have a patient and their Gail model lifetime risk comes back to be 30%. What do you do? So one very good option is going to be endocrine therapy. And we break this down into whether someone is premenopausal or postmenopausal. And the studies that have looked at endocrine therapy started at age 35. So there's really no data in using endocrine therapy for prevention in women under age 35. So the first study was NSABP P1, and that was a prospective randomized study. They had about 13,000 women enrolled, and half got placebo and half got tamoxifen for 5 years. And overall, there was a 50% reduction in the risk of breast cancer. That included the risk of developing invasive breast cancer as well as non-invasive breast cancer. Now, tamoxifen, of course, does have side effects, about a 1% increased risk in DVT, stroke, endometrial cancer, cataracts. You can get a transient hepatitis, which is reversible. And so you certainly don't want to use tamoxifen in people who already are predisposed to have risk factors. If they've had a DVT, of course, you're not going to use it. If they have high risk factors for stroke or smoke, if they're smokers, you probably don't want to use it. I mean, I think we're more reluctant to be aggressive with prevention in terms of side effects because we're not treating someone with an invasive breast cancer where we're trying to get a survival benefit. We are trying to prevent a disease that they don't presently have. So we certainly need to make sure that our patients are healthy enough to take these medications. In postmenopausal women, there was another randomized study that randomized to tamoxifen compared to raloxifene, otherwise known as Evista. And it was found that they were equivalent in reducing the risk of invasive breast cancer. Tamoxifen was better at reducing the risk of non-invasive breast cancer, but the side effect profile of Evista was better in that it did not have an increased risk in endometrial cancer and it did not increase the liver function test. So even though tamoxifen is better at preventing non-invasive breast cancer, it really was declared raloxifene the winner because of better side effect profile. So for most postmenopausal patients, if they have a uterus, we do recommend raloxifene. The other thing to know about the benefits of endocrine therapy is that on subset analysis, when they looked at patients who had atypical ductal hyperplasia, there was an 80% reduction in the risk of developing breast cancer. So this is very, very effective, particularly for people who have atypical ductal hyperplasia. So endocrine therapy is certainly an option, and I don't think that I would recommend it to someone who was 1.8% 5-year risk. That's pretty low. But you want to look at the whole profile. And if you have someone who's high risk, and it may be something that they would want to consider. So it's really important to screen patients for hereditary breast cancer syndrome. So first I'm going to talk about risk factors for hereditary breast cancer in a person who is diagnosed with breast cancer. And then I'm going to talk about the asymptomatic patient who's there for her yearly checkup. So when someone comes to us and they actually have breast cancer, what we look for to trigger genetic testing is anybody who has breast cancer and they're under the age 50. There's about a 10%, even if they have no family history, doesn't matter the ethnicity, about a 10% chance they would have a genetic mutation, and so we would recommend testing. Triple negative breast cancer, anyone who's under the age 60 who has triple negative, we would recommend testing. If they have bilateral breast cancer, if they have breast cancer and there's a family history of ovarian cancer, if you have a male with breast cancer, that is more likely to have a genetic mutation. And certainly if they're of Ashkenazi Jewish descent and they have a personal or family history of breast, ovarian, prostate, or pancreatic cancer, these are patients that we would refer to our genetic counselors. In terms of the patient who just comes in for their annual checkup, what should you be looking for to see if they're high risk? So do they have a family history of, typically this would be premenopausal breast cancer in young women. Do they have a family history of ovarian cancer? Do they have a family history of bilateral breast cancer or male breast cancer? Or 3 or more family members with breast cancer on the same side of the family of any age. Okay, so if you have mom and 2 maternal aunts, that would be someone that you would want to refer for testing. Or 2 or more family members with breast cancer on the same side, one being age 50. So if you have a premenopausal patient family history, that reduces it to 2. Or, of course, if there's a BRCA1 or 2 mutation in the family. And so what's important is referring a patient to genetic counseling is not ordering a genetic test. The genetic counselors really provide a lot of education about what the results of a test could mean. And we do have a genetic counselor at MUSC, and people can just do referrals. This is something that there's really it changes every year. There's new data, and it's something that really referring to a genetic counselor can be very beneficial. This is a risk of developing breast cancer if you have a BRCA mutation. So the blue is a general population, and the brown is if you have a mutation. So breast cancer by age 50, about half. Breast cancer by age 70, about 87%. And then if they have breast cancer, a second breast cancer by age 70, about 64%. And this is a really high number. This is from Myriad. Typically I've seen numbers about 15 to 30% lifetime risk of developing ovarian cancer. So that number that Myriad gives I'm not sure where they got that from. That's pretty high. But basically what we tell patients is that there's about a 50 to 80% lifetime risk of developing breast cancer if they do have a BRCA1 or 2 mutation. Now, you may have heard that nowadays we don't just test for BRCA1 or 2, there's something called panel testing. And it's been recognized that there are other genes that are responsible for breast cancer other than BRCA1 or 2. And so nowadays, patients typically will have a whole panel of genes that they'll be tested for, including P53 for Li-Fraumeni syndrome, P10, CHEK2, PALB2, BRIP1, ATM. And so, again, this is something that, this is why the genetic counselors can be very helpful in interpreting the data. And if somebody has, say, a mutation in CHEK2, they don't have the same risk of developing breast cancer as someone with a BRCA1 or 2. Here, their risk can be about 5 to 20-fold, where there are some genes where they might have a 1.5 to 5-fold. And so there's different recommendations about should we do screening, should we do prophylactic mastectomy. There's other genes that are tested for that really are only mildly penetrant. And I put this up just to know that, again, that this is an expanding area that really requires a lot of knowledge, and the genetic counselors can be very helpful. Okay, so here's a question. My patient has a sister with breast cancer, and my patient had genetic testing, and the results came back with a variant of unknown significance in BRCA1. Should she have a prophylactic bilateral mastectomy? Yes or no? So variant of unknown significance in BRCA1. Okay, so let's talk about variant of unknown significance. This is very important. So you're going to get a report back, and if they have a mutation, then that means that there's a mutation in that gene, and that's something that you want to take action on. Okay, so they have a BRCA1 or 2 mutation. You want to talk to them about either high-risk screening or prophylactic mastectomy. So there's something called a variant of unknown significance, and this is always included in the report. But what's really important to know is at present, when there's a variant of unknown significance, when it's classified as that, there's no data to show that that variant is associated with disease, and that needs to be treated as a normal result. Okay? And so that's really important, because patients should not be having bilateral mastectomy if they have a variant of unknown significance. And what Myriad does is they actually keep track of these patients. And over time, if they find that there's data that these variant of unknown significance actually are significant, they will actually contact the referring provider and the patient and let them know we have new data now to show that this actually is a mutation and you should take action. But it's very important. This is, again, the whole problem with false positives. This is what should be considered a false positive. If there's a variant of unknown significance, do not recommend bilateral mastectomy. This is essentially normal, and the patient might want to check back with Myriad every 2 to 5 years and say, is there any more data? They also will it'll come back as either a variant suspected benign, and that they really have more data to show this is not relevant. And then they have variant suspected pathogenic, which means that there's some data to suggest that it's pathogenic, but it's not clear-cut. And those you might want to take a look at the family history and really talk to the patient about. And polymorphisms are reported only if requested, and so that's not really important. But I just wanted to bring this out. And again, this is why it's really good to have a genetic counselor involved, because you don't want to be having patients undergoing unnecessary treatment for something that doesn't matter. So what do we do if somebody has a mutation in BRCA1 or 2? Well, one option, again, so we counsel them, 50 to 80% lifetime risk of developing breast cancer. One option is a prophylactic bilateral mastectomy. And studies have shown that this reduces the risk of developing breast cancer by 95%. So this is a very effective method of preventing breast cancer. Initially, people had mastectomies where most of the skin was removed, and then the skin-sparing mastectomy technique was developed, and this is where you make an incision completely around the nipple-rear complex. You remove the breast tissue, but you save the whole skin envelope, and that came out really good. And more recently, what's really been shown to be safe is what's now called a nipple-sparing mastectomy, and I'll show some pictures of that. And The nipple-sparing mastectomy has really been investigated since about 2000. So there's about 15 years of data on it now. So prior to these studies in 2000, to save the nipple was considered heresy for surgeons because the old data published by the Mayo Clinic was a different technique called a subcutaneous mastectomy. And what that was is when the surgeon left a very thick fat pad underneath the nipple areolar complex. The thought being that you had to save the nipple, you had to save the blood supply. And so they made thin flaps all the way around, but left a mound underneath. And it was shown a high chance of developing breast cancer if you kept the nipple areolar complex. And so all of our surgical training, it was always taught that you do not save the nipple. And then in about 2000, some surgeons started to question this. And what they didn't question is, can we leave a big, thick area underneath the nipple? The question was, what if you only left a millimeter on the dermis, like we do when we do a mastectomy? We only leave about a millimeter of subcutaneous fat. So we try to remove all the breast tissue. We leave about a millimeter of subcutaneous fat. And they said, what if we just carve out all the breast tissue, just leaving about a millimeter, taking all of the ducts from underneath the nipple? And so this is something that's been extensively studied by multiple centers in the United States. And you can get nipple necrosis with this about 10% of the time. So that's something that you counsel the patient. We can try this, and if the nipple dies, we're going to have to do an ellipse and take it off. And so patients have to sign consent that they understand that. But for the other 90% of patients, they will still get good perfusion of the nipple areolar complex. And it's amazing the cosmetic result and that you can get when you preserve the nipple areolar complex. Now, there's no preservation of sensation, and that's something that we tell patients. This is really purely for cosmetic. And when patients have bilateral mastectomies, they typically choose to undergo reconstruction. A patient, of course, can have no reconstruction. Most patients that have prophylactic surgery do want reconstruction. And so there's different types of reconstruction. The easiest is really when you have a tissue expander placed. Traditionally, that goes underneath the pectoralis muscle, and it gets expanded out over several weeks. So you expand the muscle slowly over time. And then there's an outpatient procedure where the plastic surgeon will then remove that and put in a fully the final implant. What's nice about this procedure is that it only adds a couple hours to the operating time of the mastectomy. It's only about 1 to 2 days in the hospital, and the patient has a breast mound. And so it can be a very good option for patients. The downside of having the expanders and implants is that it doesn't feel natural because it's not. Okay, it's going to feel like an implant. It doesn't feel like normal tissue. In my experience, there's a lot of pain with this procedure. When you put it underneath the muscle, these are the patients that have the most pain after surgery. We are very aggressive to try to minimize pain. We put in epidural catheters. We are very aggressive about muscle relaxants. But even with all of that, this is a more painful operation. The other types of, and there is a new procedure that our surgeons at MUSC are doing, and it's where they're actually putting the implant on top of the pectoralis muscle, and they're wrapping it in alloderm. And so by not putting it underneath the pectoralis muscle, you're reducing a lot of the pain. And so far, the results look very good. So this is a new procedure, and I think this is going to have a lot of benefit for patients in terms of pain. The other types of reconstruction is when you move the patient's own tissue around. And that can be where they take the skin, fat, and a little bit of muscle from the abdomen and recreate a breast. They can take it from the latissimus dorsi muscle. These are bigger operations, can be 8 hours or so, but they do have generally very good results. And so this is just a picture. I just took this from the internet of nipple-sparing mastectomy. And as you can see, when you save the nipple areolar complex, you really can do a good job at cosmesis. And so for someone who has a 50 to 80% chance of having breast cancer, this is really a good option that they can consider. There are of course potential for complications, and we counsel patients about that. So if the patient, I'm just going to say for patients with BRCA1 or 2 mutation, they may not want to have prophylactic mastectomy, and so those patients would then get screening breast MRIs in addition to screening mammogram and every 6-month clinical breast exam, and so they would be followed as a high-risk patient. So these are the screening recommendations for high-risk patients who do not choose to undergo prophylactic mastectomy. So if they have any family history of breast cancers or in the first-degree relatives, so they should start screening mammogram 10 years younger than the youngest affected person. So if mom had breast cancer at 45, your patient should start her screening mammogram at age 35. So for people who are at high risk, all of the USPTF and American Cancer Society recommendations I was talking about, that's not relevant for the high-risk population. They have a family history, you want to start 10 years earlier. And although this hasn't been well studied, these are the patients that we do recommend the clinical breast exam twice yearly. And if they're seen in a breast center, what can be really nice is one of those exams can be by the primary care provider at 1 6-month interval, and the other one can be with a breast surgeon when they're having their screening studies. And they get yearly mammogram and yearly breast MRI. So I just wanted to show a picture of a breast MRI and how it's different than a mammogram. So, let's check the time here. So mammograms, as I said, one of the problems with density, that has no effect on breast MRI. Breast MRI is really looking at blood flow. And so tumors, as we know, require angiogenesis or new blood vessels to grow. And so when you do a breast MRI, you can see the tumor, the vessels coming in, and the whole lesion is going to enhance because of the blood flow. And so this is a way to detect breast cancer. It's actually more sensitive than screening mammography. The problem is that it does have a higher false positive rate, and that's why this is only done in people who are at high risk. So an MRI does require an IV. It does require contrast. And if you combine mammogram and MRI, the sensitivity of detecting breast cancer is about 93%. If you compare that to mammogram and ultrasound, the sensitivity is only 52%. And so breast MRIs are indicated and will be paid for by insurance if you have a greater than 20% lifetime risk, if you have a BRCA1 or BRCA2 mutation, if you have a biopsy that has LCIS or DCIS or atypical hyperplasia, or if you've had prior chest radiation. So in conclusion, I think what we want to be doing with our patients is we want to, first of all, decide, are they at average risk for breast cancer or are they at high risk? If they're at high risk, you want to triage that appropriately. For average risk women, certainly, I recommend screening between age 40 to 45, but I think that really the American Cancer Society recommendations are very good. At least start screening at age 45, and it really should be a balanced discussion with the patient about what their goals are. And it's very important for the primary care physicians to really do risk analysis and identify women who are at high risk for breast cancer. So I'm happy to answer any questions, and thank you for your attention.